So as I mentioned before, I work for an organization called ADOS. You can see it right there. Mnemonic device. It's like a dose of joy, ADOS. We are specializing in LGBTQ health, trying to get solutions out to users now and in need. And the reason we focus on LGBTQ health is this is already a huge need in this country, but a growing one. So whether or not you look at the LGBTQ plus population as just 7% of the population, which is probably already a conservative estimate, 19.7% of Gen Z, almost a full 20%, identify as part of the LGBTQ plus spectrum. And so as time goes on, if the issues around health and in healthcare are not being addressed, more and more people will not having their health needs adequately serviced by the people around them and in society. So we call those things, when a group of people is not getting adequate healthcare, a health disparity. So that's actually really what we're going to be focusing on for the first part of this talk, just identifying what is a health disparity. The simple definition, or I would say, is basically anytime the health outcome for a group of people is worse than for other people, especially when they're part of a marginalized group. The two kind of major things to keep in mind when you think about health disparities are, one, it has to be something that is preventable. We'll get to examples of what I mean by preventable in a second. And it also has to be affecting a group which has been socially disadvantaged. So if we find that very wealthy people who are well educated get more paper cuts, we wouldn't call that a health disparity because rich, wealthy people are not really a socially disadvantaged group. Also, there's no evidence. I'm sure they're not getting more paper cuts. And the goal of looking at health disparities is to move toward the positive direction, health equity, right? And health equity is really, does have a simple definition, when everyone is able to attain their optimal level of health, right? We're all different. All of our bodies are different. We all have different capabilities. And so health equity might not look the same for everyone individually, but as long as a person is able to achieve their highest level of health, that is what we would call health equity, right? So looking at those definitions, I always like to give a few examples. So we're going to play a little game called, Is This a Health Disparity? And I really hope you recognize that meme. So I'm just going to give you an example of some of the different observable health outcomes we see being different from folks. We'll just do a quick thumbs up if you think it is a health disparity, thumbs down if you think it is not health disparity, and we'll kind of unpack a little bit for how that plays out. So the first one, older adults are significantly more likely to be diagnosed with dementia as compared to younger adults. So thumbs up, you think this is a health disparity. Thumbs up, you think this is down, you think this is not a health disparity. What do we think? You can also just say it if you want. There's like three of us.
I would say no, right? Oh, sorry.
No, I guess I would have a question, right? Like,
please, I love it. Yes.
So, like, are you looking at like disadvantaged groups from like the government, like a covered person?
Like a protected class?
Protected class. That's what I meant. Yeah. Versus like, like socioeconomically.
I love the specificity. And part of what this question is meant to expose. So in the United States, we do have protective classes. Because that doesn't apply like globally, we wouldn't take that exact language and apply it everywhere. But essentially, it's more sort of the second part. So like people who have historically been socioeconomically disadvantaged would be like a shorthand version of this. Oftentimes, these folks end up as protective classes in the US. So it's oftentimes synonymous, but not exactly that way. Does that make sense?
Yeah, it does. So I would say no then.
Aha. So okay, so we three no's. I love unanimity. From who does anyone understand, why is this not a health disparity? What about this doesn't ring true as a health disparity?
I don't know if this is the right answer for this, but it feels like this is something that happens due to age, regardless of any other factor. So it's not based off of something that just generally it happens as you age.
So fact one, right? We said that it had to be preventable, right? Dementia in older adults, at this point, we don't have treatments for it. It's not really preventable. So the preventability makes it something that would be hard to classify as a health disparity. There's another thing in here. So it's not just the diagnosis, the dementia, but the other part is like that protected class, that disadvantaged class. In general, we don't consider elders to be part of one of the protected classes or socially disadvantaged class, which is not to say there are not things like ageism and things you should pay attention to. But for these reasons, because it's not really affecting clearly a protected class or a traditionally socially disadvantaged group, and because it's not really preventable, we'd say this is not a health disparity. So again, health disparity doesn't just mean like a difference in outcome. It does depend on sort of the context around it. So great job. You all three identified that was not a health disparity. Look at this one. African Americans are more likely to be diagnosed with sickle cell anemia than white Americans. You'll notice this one's getting a little harder to think about. This one is designed to be a little more challenging. I'm not trying to trick you, but I wanted to give you something more to think about. So I'll do a quick thumbs up, thumbs down voting. Don't worry about being right or wrong. I'm just curious what you think, and we'll kind of unpack it again for like how we should maybe be thinking about this. But what do we think? Health disparity, yes. Health disparity, no. Okay. Oof, Andreas, you got the vote because we have two now.
I need to. I'm typing it. There we go.
Okay. Not a health disparity. All right, friends. You are correct. Textbook people. So in medical textbooks, this is often used as an example of something which is a difference in outcome, but not a health disparity. So you were all correct. Why were you thinking this one would not be a health disparity?
I think this is just a genetic thing. It has nothing to do with like something happening outside of them. You can't prevent it per se.
It's not. Yeah, exactly. It's not preventable. It's a heritable trait. And so it is not preventable. So it doesn't fit that, even though we would see African Americans as a socially disadvantaged group, as a protected class, this wouldn't really count as that. Now, I did recently get called out by someone who I thought this was an intelligent critique. They're like, do you think we'd have a treatment for sickle cell if it mostly affected white populations? And I was like, oh, that's
a good
deep.
question.
That's a good question. I was like, that I don't know, but it is interesting to think about, which diseases get prioritized, which conditions are ones that we address are still part of this fabric of racism and classism and heteronormativity, right? All those things still play a part. So even though we, again, because of the preventability, we'll keep it simple for example, we wouldn't consider this a health disparity. It does show that there be difference in outcome. All right. Last one. African Americans diagnosed with diabetes are more likely to have a seizure than white Americans diagnosed with diabetes. Is this a health disparity or not? Ponder it. Thumbs up for yes. Thumbs down for no. What do we think, and friends? All right. You have done 100%. You've gotten all of these correct. So yes, this is another sort of what I'd say is like a classic example of what is considered a health disparity, right? Because this is clearly preventable, right? If one population is experiencing it at a much higher rate than another population, and because diabetes has been widely studied, we can also look at it in terms of income level, education, other things. Still seeing that disparity means that there's something else happening here. There's a deeper root cause that needs to be addressed, all right? And so this is when we talk about LGBTQ health disparities, right? A lot of times it is looking at a picture and trying to figure out why, when we balance for other identity traits, why do we still see different outcomes for these people? Again, it should be preventable, but does not appear to be. All right. So any questions for me before we move on about just like what is a health disparity?
No, I have a more more specific question around how something becomes a health disparity. Is there especially with the way in which studies are rolled out, could it be like a factor of like sampling bias where they're not able to select a full a true sample of the population, and so that's why it becomes a health disparity, because they're only really creating interventions for other populations that aren't representative of the entire, or other samples of the population that aren't representative of the true population.
Yeah, so this gets, your question is a statistics question, so I will give you the answer that I can give you. Mm-hmm. But I will say, when things get labeled a health disparity, there is often a lot of internal hand-wringing and decision-making, right? How big does a study need to be done to be considered representative? Are you accounting for geographic distribution, for age, for a whole host of factors? So oftentimes when an issue is labeled a health disparity, there is still lots of debate about to what extent, how commonly can it be traced along a whole population who are part of this group. So there is even like just to label something a health disparity, sort of like that's where you kind of start. Like we notice this difference in outcome. Then a lot of work comes into unpacking how do we sample for this? Are we sampling correctly? How specific can we get with it? What are the exact precursors? What are the exact outcomes that we're seeing to really file down? So it can take a long process to really kind of get to that detail level. Does that answer your question?
Yeah, it does. So it's like it's more complicated. Like it's not the result of like one. It's not one thing. It's a combination of a whole different bunch of factors that create it. Okay.
Exactly. And we're actually going to hopefully get to some of the things about that in my next slides. So now that we know what a disparity is, I want to talk a little bit about what are the LGBTQ plus health disparities. What do we see? Before doing that, I just want to give this little disclaimer, which is that even sharing this knowledge and talking about health disparities can unfortunately become problematic in and of itself, because it becomes very easy to stereotype and to stigmatize groups and identities for having health disparity. Very often the disparity is blamed on the population themselves. And also very commonly, populations become synonymous with a disparity. The example I can give you historically is in the 80s and 90s, a problem that a lot of gay men face is that being gay was like synonymous with having HIV or AIDS, right? It was a health disparity. It did much more affect that population, but it became stigmatizing because it was like that became part of that identity in some ways for people outside. So as I talk about these, I do want to kind of just mention that we have to be careful as we pay attention to health disparities so we can address them, that we don't accidentally stigmatize the communities that we're trying to bring in and help. The other thing I'll mention is just your point, Andres. The estimated rates of disparities can vary between studies. I mean, sometimes for certain conditions and certain populations, we don't have like a very large longitudinal study to really tell us a lot about it. So we can kind of estimate that disparity. And then the final one I will give you is that LGBTQ, it's a great acronym. Not everyone in that not experiences these disparities in the same way. So disparities that may affect lesbians different than gay men, different than bisexual people, different than trans people, different than queer and questioning people, different than intersex people, different than asexual people. So even though I call it an LGBTQ health disparity, that's kind of an already oversimplification. Each group is going to have a different experience with these sort of issues. So having said that, let's talk a little bit about them. So I picked sort of 5 different places where we commonly do see LGBTQ health disparities. And I picked them partially because I wanted to focus on, there's a tendency to focus a lot on sexually transmitted infections, STIs, as like a common place. And we can kind of see that in the legacy of HIV. But there are other health disparities that are also very prevalent that don't get as much time. So the one I'll actually start with is cancer. Cancer rates vary, again, widely by different parts of the LGBTQ plus umbrella, but all LGBTQ people are more likely to develop cancers than cis heterosexual populations. One of the most prevalent and kind of simple one of these is lesbian women are more likely to develop breast cancer than straight women. And again, this is a great time when there's not been enough studies for me to say 4 times more likely, 1.5 times more likely. There is debate about how specific we can get with that. What we can say is across studies, we do know that lesbian women are more likely to develop breast cancer. Right? Another one, mental health conditions, another one that you're more likely to experience as an LGBTQ plus person. But actually, bisexual adults are twice as likely to experience symptom depressions of not just cis hetero populations, but also lesbian and gay populations. Or I shouldn't say 2 times as likely, but still more likely. So of that umbrella, bisexual are some of the most likely people to experience symptoms of depression. So again, not equally distributed among the LGBTQ plus umbrella. Substance use and misuse. So smoking is often considered one of these, using drugs. Gay men report higher rates of tobacco and alcohol use than the general population. And so some of the highest per capita users of tobacco products are gay men. Many reasons to unpack for why that is. But again, it's interesting to note this disparity when we talk about how are resources allocated to addressing a health disparity. Cardiovascular disease, so heart health. Trans men are more likely to have a heart attack than either cisgender men or women. So again, noting that heart disease is a major concern, a major issue. And then, of course, I will talk a little bit about STIs. Like I said, as a whole, across the LGBTQ plus populations are more likely to have higher rates of STIs than straight cis populations. But the reason I want to end with that one is, again, I think this can be one of the most commonly stigmatized ones where this has become associated with parts of the community. And really, it's not how can I say it? It's not endemic. It doesn't have to be this way. It is, again, a preventable thing, we believe. There are ways. It's just that the system hasn't been designed for it. So I'll pause there and take a question from Amanda, please.
Question for you, especially about the cardiovascular disease question. And this does play, I think, or statement. I think this does play into what Andres was talking about earlier, potentially. This is an assumption on my part, but I'm assuming if you studied 100 people, the number that would be trans men versus the number of people that would be cisgender men or women would be very different in terms of population. So for total ease, let's just say that in that population of 100, there were 10 people that identified as that were trans men, and then there was 45 cis women, 45 cis men. Hopefully my math is correct. Well, then if 2 trans men had cardiovascular disease, their rate of cardiovascular disease is 20%. Whereas if 2 cisgender women did, it's going to be a much lower rate. Is that what's impacting this, or is it solely just population?
It's controlled for like within the population. So so it would not be, so if you had it would be percent of the total population. The sampling is made to take that into account. Yes.
Okay. Thank you. That helped. I was just curious because then I was like, well, of course your percentages would be higher if your populations are smaller. But
no, of course. But also, like, this is STEM. Let's not get it wrong, right? One of the reasons why it's hard to sort of talk about these studies specifically is like people publish lots of studies. Unless you're really reading the fine print of all of them, it's like sometimes sampling does happen that way. And that's why, again, once something is flagged as being a disparity, a lot more research needs to be done to find more information, right? Because the study of trans men could be a study of trans men and heart disease where it found of the 200 participants of this study, 2 had a heart attack. And they compared to other studies of straight cis populations, which tend to be bigger, larger, and run more often. And that's what the comparison that should be happening. But again, unless you're reading the fine prints of the studies, you don't always know.
That makes sense.
Also, I will say famously or something to pay attention to in public health is you do sometimes read a study that the N was 15. You're like, okay, well, 15 people, let's good to pay attention to, but we need a bigger study. And actually data and how we collect data is going to be something we're going to talk about a little bit later. So thank you for that question. All right, I'm going to keep it going, friends. So these disparities exist. One of the things that I think is really interesting to think about, and especially for students taking classes, is when disparities come up in conversation, if they come up in a class that you're in, there's kind of 2 ways that people talk about them and why they exist. One is what I call the lifestyle story that people will give you, which is that for LGBTQ plus people, it was that the reason that LGBTQ people have worse health outcomes is they make worse choices. They engage in risky behaviors. That's why they have these bad outcomes. Now, not to take choice out of it, not that people don't make choices, but there's also a systemic story, which I think is how in population health and in public health, researchers would look at it now, right? How does the system support getting health solutions? How does the system support conversations about these topics, right? If you were... for example, if you were a kid in a school that didn't have any sex education because you received religious education, right? That became part of your system, that where you got information from, where you were able to, is important. If you had a health class that was about preventing STIs, but you didn't feel comfortable as a gay student asking questions how that affected you, that was part of the system, all right? All the sort of things that are around you that support you knowing about a topic, being aware of it, knowing how to address it, are part of what health researchers call the social determinants of health, right? So I definitely was guilty of this for the longest time, I thought that health was like doctors, nurses, hospitals, prescriptions, medications. That was health. What affects your health is everything around you in your system, right? So it is whether or not you, like social determinants, like do you have your socioeconomic status, your housing status, your racial identity, your sex identity, whether or not you have a job or not. It has to do with inequalities in policies, right? Legal rights, insurance coverage. It has to do with lack of access and lack of knowledge, going to a doctor and them not knowing about your particular needs as a gay, lesbian, trans, queer person. It has to do with safety and environment. It has to do with the way information is siloed and the way that researchers don't always talk to policy people, don't always talk to educators, and that disjunction. And then, of course, stigma, right? The fact that LGBT people is a stigmatized identity. So all these things around you that have affected how you learned about a topic, how it was normalized, how it was socialized with you, are all part of your health and well-being. And so when we talk about let's talk about cancer. And so instead of talking about cancer as like a risky behavior, bad behavior, why is there an LGBTQ health disparity in cancer? And there are some reasons for this as part of this like larger network, the system that helps keep you healthy. One is called the presumption of care gap. All right. So throughout much of the 70s, 80s, and 90s, if you disclosed to a doctor that you were LGBTQ+, they could deny you care. They said they didn't want to treat you anymore. For that reason, a lot of LGBTQ people didn't go to the doctor. They didn't get cancer screenings, which means that something could have been caught way earlier before it became a malignant cancer, wasn't caught at all. So for a whole generation of LGBTQ people, they didn't get those screenings. Also, because of that, because for so long that was a normal thing, there is still a thing in many places where a lot of LGBTQ people think they can't get care, even if they can. So it's the idea that's called the presumption of care gap. Just like people, not all queer people presuppose that they will be treated, and so they just don't go to the doctor. So it just like prevents people from even going. So that's one reason for the cancer disparity. Another one, systemic data suppression. So these studies, how we find out about health disparities, right? For a long time, a lot of the studies in health outcomes, people weren't asked and they didn't collect sexual orientation or gender identity data. So they never knew how many people in the participants in these studies were LGBTQ+, right? And that meant that we didn't know how many people this was affecting, right? So for lots of studies of breast cancer, they took all the information, but they didn't ask people their sexual gender identity, which means that the disparity was invisible. Unless you collect that data, you don't know about it. There is a saying, which I've heard more recently being used, data is violence, right? What you measure matters, right? So if you're not measuring something, you're not looking for these disparities to find them, you won't, which means they won't matter, which means people won't know, which means there can't be treatment plans, which means there can't be research, which means we can't analyze the system. So the fact that data is not always collected with sexual and gender orientation in mind is a big hurdle. By the way, President Biden recently signed an executive order mandating that a lot more studies are required to collect this data. So we will have a better sense of this as time moves forward. The other thing is the idea of awareness campaigns, right? To this day, I have never seen a cancer screening awareness campaign aimed at LGBTQ+ people. I just haven't. To be fair, I've not seen a lot of these in general, but you often do see things in magazines or commercials about cancer screenings, things like that. I've never seen one aimed at an LGBTQ+ audience. So a lot of times this message just isn't received. It's not in periodicals that LGBTQ+ people are reading. It's not in the movies they watch. It's not delivered by people in their own sort of with their own kind of cultural references. And so because that awareness campaign isn't there, people don't know. Now, even though LGBTQ people haven't had awareness campaigns, what they did get for a long time was marketing from tobacco companies. So especially in the early kind of era of pride parades and pride movements, a lot of businesses didn't want to sponsor them, but there was a few companies that would. Tobacco companies and alcohol companies. Now, great, that money was great for having community celebrations, and they allowed Pride to exist and to grow. But because of that, a lot of people got marketed to very directly in spaces that were made very safe for them. So that message was very well received. And so we see this high rate of tobacco use, which is, of course, going to lead to more cancer. And so we see how this cancer, which doesn't seem to be connected to a queer identity at all, when you look at that systemic view, that you zoom out to see all the things that could have supported being healthy, they just weren't there. And so when I say that something is systemic, I don't always mean that there's like a villain behind the scenes being like, I know how to get the LGBT people. It's a lot of times things within the system working in such a way that just services aren't there. Knowledge isn't relayed. Gaps. Yeah. All right. So that is the systemic story. That's how we can look at a health disparity and see why it exists. Another thing I do want to bring up is the minority stress model, which is another way of looking at why we see health disparities in this way. So essentially, of any sort of minoritized population are going to experience things like microaggressions, violence, discrimination, stigma, more likely to have issues with family and peers. And of course, these things are magnified intersectionally by other identities, right? All that accumulated stress has an impact on the body. It forces your body to release more cortisol to sort of deal with the stress going on. And so sometimes this causes things like it can have similar effects to like a long-term PTSD diagnosis for some folks, but also kind of weathers the body. It puts more pressure, more stress on the organs. So also aside of that sort of systemic things of being there to support you or not support you, there is that sort of minority stress, which can also sort of contribute to these issues as well. Right, so that's another reason why we see a lot of these health disparities and why they can be so generalized in very different ways, because it's a reaction of the entire body. So that's another way of sort of looking at it. So talked a lot about the challenges. I do want to talk a little bit about the solutions, because I don't want to leave you with the sense that like there's this mountain to climb and like no one's doing the work or there aren't things in place. There are things in place. So things like the government sector, right? They fund research through the National Institutes of Health and other ways. They fund health centers, FQHCs. I think in DC, William Walker is the big FQHC there providing LGBTQ plus health.
Yep.
In Philadelphia, it's the Mazzoni Center. The government also sets official policies. So they are folks intervening in this. Like I mentioned, the Biden executive order about collecting SOGI data when you're doing research. There's something to know about that, though. So last year, a survey of the portfolio of projects funded by the National Institutes of Health found that less than 1% of the projects funded for research were for LGBTQ plus users. And of those, most of them were focused on just HIV. So if you were an LGBTQ plus person with any other health concern than HIV, there was very little research for your needs. All right. Another sector involved in solving this, philanthropy, nonprofits, right? The people who collect money for causes, the people who run awareness campaigns, the people who advocate for better outcomes, right? Definitely doing this work. But for every $100 awarded to a foundation, 23 cents goes to LGBT plus health. All right. So a small percentage. And then the last one we'll talk about is the business sector. They're supposed to make products that will scale and fit people's needs. Of the $2.5 trillion that went to startups last year, 0.5 went to LGBTQ plus entrepreneurs, which is not even to say that those entrepreneurs are doing LGBTQ plus health. So this is not the best statistic. It was just the only statistic we could really find on this topic. But the idea is like, these are the people who are supposed to bring the solution, and they're not doing enough. Not that they're not trying, they're doing so much. And I never want to denigrate this. I always think it's important to remember the work to address these disparities has always been happening, right? Queer folks have always been trying to address these disparities. They just haven't always had the bandwidth, the support to do it. And that is one of the things that I think ADOS is really kind of aiming to change, right? So this is our founder, Dr. Jose Bauermeister. His kind of philosophy is that this great work has always been done. There's always been amazing people advancing the needs of queer folks needing better healthcare. It's just they've operated independently. And so our vision is what happens if we make sure that all the people across these sectors are talking to each other, that they know what's going on, that they're in lockstep on these sort of things. So that if there is a social policy that will benefit employers, business knows about that. Healthcare people know to ask those questions. Government policies can support, though, can be in line with those policy recommendations. That if academics are doing research about helpful interventions, business people know about them so they can scale them and make new solutions quickly. And so essentially, I call this the Adosian web. It's trying to mobilize all the folks possible to sort of do this work to make sure that we are advancing LGBTQ health as quickly as possible. And we're getting these solutions in the hands of users. So sometimes people ask me, like, so what can I do, right? So ADOS is going to change all these health disparities. We're working to connect folks. How can I be a part of this? Or how can I be part of this in general, not even with ADOS? One thing is, there is an article. I should have sent this to you in advance, Amanda, but I did not, but I'll send it to you later. We did a primer on our website, pennados.org, just talking about these health disparities, causes of them, and ways to address them. All right. What are the things that we can be doing, like collecting better SOGI data, like I mentioned before? All right. Another one is, when you're hearing people talk about these topics, listen for the narratives they're using. Are they describing this health disparity in such a way that it is the fault of the marginalized community? Or are they talking about the system around it? How are they understanding this problem? How are they framing it? Because that's very important for the conversation you're going to have. The other thing I would advise you to do is, as students, as learners, if there's a topic going on and LGBTQ people aren't being mentioned in that discussion, feel free to raise your hand. Professors often like it. Like, what was the experience of LGBTQ people with this issue, right? If you don't feel comfortable doing it in person, which I totally understand, an email after class. In my experience, professors actually really enjoy this because they love their topic and they know they're boring people. So they really want you to ask them questions. So that's a way to kind of make sure that we're getting this knowledge as we need it. The last thing you can do, if you want to, here's a QR code for the ADOS newsletter. You're welcome to subscribe. We send out information about different projects going on, different projects that we work on, different speaker series we have to talk about some of these healthcare disparities. And you're always welcome to join. It's just a good way to sort of know what's going on and sort of be connected. Because at the end of the day, our philosophy is we're all already doing lots of great work. Let's just see if we can do it together.